So, because this narrow QRS tachycardia is a common clinical problem, I'll just try to touch upon the management also a little bit. The most important thing a lot of time you feel is, do you have to cardiovert or not? If any patient who has any form of tachycardia, may it be a narrow QRS, wide QRS, and has a evidence of a hemodynamic collapse, you are going to cardiovert them. If a patient has a narrow QRS tachycardia, at the same time, patient has evidence of cardiac ischemia, patient complains of chest pain, there is a significant ST changes, you can consider cardioversion. The patient has developed a tachycardia-induced heart failure. Patient is presenting with a heart failure with a background narrow QRS tachycardia, you can consider cardioversion. In atrial fibrillation, cardioversion, you have to be very careful. If the patient is hemodynamically unstable, you have to cardiovert anyway, but you have to keep the patient relatives to understand the risk of stroke. It's between life or death situation. When you have a atrial fibrillation, patient is hemodynamic collapse, you can try to cardiovert them. Most of the time, we convert with loading them with heparin. We give around 5,000 units of IV heparin before cardioverting. Sometimes you can have a look at ECO, but it's very difficult. When the patient is hemodynamically unstable, you are going to cardiovert irrespective of the stroke risk, but you have to keep the attenders informed. Most of the time, because any patient who is a hemodynamic compromise with a tachycardia, you have to follow the ACLS protocol. So most importantly, if you have to diagnose properly, will guide you in the treatment. To treat effectively, you should know all the differential diagnosis possible. You have to use the patient clues. The ECG is one part of diagnosis. You should know the background history, how it started, what is the past history of the same disease, and always obtain a 12-lead ECG. It's very important because when the patient is hemodynamically stable, there's no hurry. You take a 12-lead ECG because it's going to help you in telling the patient what is the further prognosis, what he has to do next, what drug you are going to give him, are you going to advise him a radiofrequency ablation, all depends on the diagnosis. So you try to take a 12-lead ECG all the time. Always have a quick look at the ECG. Just look at the narrow or wide. Is it regular or irregular? Is there any pre-excitation in the previous ECG? Is there any ischemic changes in the ECG? Hemodynamically unstable, as I told you, there's no need for you to look at anything, just cardiovert the patient, irrespective of the diagnosis. If the patient is clinically stable, then you have time. Take a 12-lead ECG, you can think and act, you have a diagnosis, you can give a drug according to your diagnosis. Always, whenever you are dealing with an arrhythmia, have a proper IV line, connect cardiac monitors on, give oxygen if required, immediate cardioversion if patient is unstable. If you are not going to cardiovert also, you keep a defibrillator close by. Don't run to the defibrillator when patient has developed a serious arrhythmia. Valsalva is most effective when given early. Carotid massage is very effective. Facial immersion is particularly, facial immersion in cold water is very useful in infants. Vagal inverts are usually not very effective when your PSVT is running for some time. The patient comes with a PSVT into your emergency within 15-20 minutes of starting of the arrhythmia, it's easily to terminate. So most important thing is most of this vagal maneuver start to the patient, because the patient can start early and terminate his arrhythmia. When the patient reaches the hospital, you can always try a vagal maneuver. If you are terminate, very good. If you not, you can use a drug. The most common drugs we use for converting your PSVT is most commonly available drug is either diltiazem or an adenosine. Diltiazem is cheaper. It's as good as adenosine in converting an arrhythmia. Usually give a 15 to 20 mg IV over 2 minutes. You can repeat with a 20 mg dose or 25 mg dose if the patient is not terminating. The only problem is you have to look at blood pressure. If patient has a good blood pressure, diltiazem is an excellent drug. You can use diltiazem to terminate the arrhythmia. The other drug, which is adenosine, is most commonly used because ease of admission and good peripheral or a good central line. You have a good bolus of 15 to 20 ml of normal saline. Give a adenosine bolus, flush with the saline so that it reaches the heart. The biggest advantage of adenosine is short acting. The moment you give a adenosine, it goes there and 5 to 10 seconds, it terminates the arrhythmia. You don't develop much of hypotension or any big issues. Because you have two drugs which are very good, when you use adenosine, when you use diltiazem, or can you use both in any patient? This is usually decided by, I can give a little information on this. You prefer adenosine if the patient is a neonate or an infant. If the patient has a hypotension, if the patient has evidence of heart failure, if a diagnosis is uncertain, or if the patient has a prior beta blocker. Because if you are going to give a patient with beta blocker, giving a diltiazem again can cause a hypotension or a synergetic effect of beta blocker and calcium channel blocker together. If the patient is a routine if you have a poor IV access, if you have a small line in the hand, some 21, 22 gauge line, and if you are trying to give adenosine through the line, you are unlikely to reach heart. So that time I would rather prefer a calcium channel blockers. The patient who was already on dipyridamole or a post-transplant patient, they don't respond to adenosine, or a patient who was on theophylline, or a history of an active bronchospasm. Some patients are very reactive airway disease. There you may have to avoid adenosine because they can precipitate a bronchospasm. In long-term management, most common drugs we use are calcium channel blockers, beta blockers. We don't usually use antiarrhythmics in these patients. I rather take them for a radiofrequency rather than giving a long-term antiarrhythmic therapy. As I told you, catheter ablation or radiofrequency ablation remains treatment of choice for most of the arrhythmias because radiofrequency ablation has become very simplified procedure available in most of the places right now with a very low risk. So any patient who has a supraventricular arrhythmia who does not want to consider the drug, or you have given a drug and patient is not effectively controlled with the drug, or patient has a lot of side effects with the drugs, you can consider a radiofrequency ablation if patient has a AV nodal re-entry. But if the patient has a WW syndrome, your catheter ablation remains class 1 because the patients with WW syndrome, although may look very benign, they run a risk of sudden cardiac death if the pathway conducts atrial fibrillation. If the patient develops the atrial fibrillation and the atrial fibrillation goes through the pathway, it's a life-threatening condition. So the patients with WW syndrome, it's better to for the first arrhythmia, intermittent tachycardia or atrial tachycardia, where you may try drugs if the patient is not very keen on radiofrequency ablation. So thank you for your wonderful listening.